Yeah, I think the story of the evolution of treatment of metastatic renal cell carcinoma is one of the nicer stories in oncology. To put it into perspective, around 20 years ago, the expected survival we would have with these patients would be around 7 to 8 months, and the treatment options that we had were highly toxic and clearly not very effective. So with the development and adoption of immune checkpoint inhibitors in their form as anti-CTLA-4 and also as anti-PD-1 agents, we have been able to develop new and more active treatment options, either with a combination with an anti-angiogenic TKI or a double immune checkpoint inhibition combination, leading to longer survivals, I want to say 4 times as long, as well as better quality of life and better responses to the treatment. So this definitely has made significant progress in patients' lives. Choosing the first-line treatment for a metastatic renal cell carcinoma is complex, and clearly the complexities stem from several factors. As mentioned, the lack of head-to-head comparisons. All contemporary trials were compared against sunitinib instead of each other, as well as a lack of standardization for predictive biomarkers. Clinicians usually consider several factors, such as the patient's IMDC risk score, as well as the patient's individual performance status, their comorbidities, specific disease characteristics, such as the presence or absence of sarcomatoid features, and also patient preference. So this is at least how we build a potential treatment algorithm to determine whether the patient would be a better candidate to start with a novel IO inhibition or whether the patient would be more suited to start an IO with a TKI combination and in a very limited subset of patients. There's also the option to give in the first line setting TKI as monotherapy. Nevertheless, this is more and more less common in our current practice. Yeah, second line treatment right now, it's probably one of the areas with the highest unmet need. And the reason for that are many. One of them is because we have many options in the first line setting. So it's kind of hard to establish a direct pathway from one treatment algorithm to another one. Additionally, as I previously mentioned, the lack of validated predictive biomarkers to determine which are the patients who could benefit from specific treatment interventions. And finally, there's limited evidence in the post-immune checkpoint inhibition treatment setting, because most of the options we had available were developed in the post-TKI setting, which we must transpolate the evidence and also take it a little bit with a grain of salt. Nevertheless, now with the evidence that we have from the CONTACT-03, as well as the TiNivo-2 trials, we understand more things. One of these is that the use of immediate rechallenge with an immune checkpoint inhibitor after disease progression to another immune checkpoint inhibitor might be a futile strategy. And we also understand that there's significant activity of some of these agents, meaning cabozantinib as well as tivozanib, after progression to a first-line therapy. Yeah, the balance between efficacy and toxicity is quite critical when we transition patients to the second and subsequent line setting, particularly now that we have more treatment options available, such as mentioned, the group that represents the anti-angiogenic TKIs, the mTOR inhibitors, as well as the more novel HIF-2 alpha inhibitors. Some factors we take into account is, number one, what was the patient's benefit of the first line if he immediately progressed after a TKI IO combination, or if the patient presented with more of a slow progression. Number two, the toxicity this patient presented, whether they had some important TKI-related toxicity, such as mucositis, such as hand-foot syndrome or hypertension, or if they didn't present it. And as mentioned before, individual patient characteristics, such as comorbidities and patient preference, are the main guiding factors we have for the selection of subsequent lines of therapy. Definitely, we have made important progress in the last 10 to 15 years, but there's so much more we still need to do. Some of the challenges we have, number one, is within the refractory disease context. Right now, we have several very interesting early phase trials. One of this based on the use of cellular therapies for patients who have progressed to standard first and second line treatment. Another area that is lack standardization is the guidance for patients who have progressed after adjuvant pembrolizumab, which is now an approved therapy for patients with localized disease. And finally, and more importantly, and something that we have made some progress with recently during ASCO with a KIM-1 molecule, is the development of better biomarkers to help clinicians determine which patients would benefit from which specific treatments. At the end of the day, what we're trying to do here is to move the needle toward a more individualist care. We want to be able to offer patients better treatments, but also treatments who would not represent an important toxicity in their life, and something that it's, I think, one of the main priorities we have right now as clinicians and as researchers.